Welcome to KidzDocTalk with Dr. Jennie. Today's guest is Dr. Hart-Unger, discussing topics in pediatric endocrinology. Sarah Hart-Unger is a board-certified pediatric endocrinologist and serves as a pediatrics residency program director. She completed her training from medical school through fellowship at Duke University School of Medicine and has been practicing at DiMaggio Children's Hospital since 2013. Her favorite thing about pediatric endocrinology is getting to know patients and families well through years of care. In her free time, she enjoys podcasting and actually co-hosts her own podcast called Best of Both Worlds about making work and life fit together, and enjoys spending time with her husband and 3 children. Welcome, Dr. Hart-Unger.
Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Hi, Sarah. Thank you so much and welcome.
Hi, Jennie. Thank you so much for having me on.
So I'm excited to talk about all things endocrine. We've never had an endocrinologist on before, so this is super. I want to start off with just tell us a little bit about like the stuff that a pediatric endocrinologist sees. What's some common things that come your way?
Yeah, that's a great question. I think that it's a little bit of a random assortment of disorders that developed historically as the profession came about, I think in the early 20th century. But we take care of kids who have all kinds of hormonal issues, and that can be too much of a hormone, too little of a hormone. And that, because the hormone system is basically controlling many organs in the body, that means we get to care for a diverse array of different conditions. So the common ones you may hear about us taking care of are diabetes. That's a big part of any pediatric endocrinologist practice, unless they specifically don't do that care, which at very large centers does happen sometimes, but not at most places. We do lots of growth disorders. We do thyroid disease. We do anything related to puberty. We take care of patients with obesity and insulin resistance, and then bone and skeletal health as well, although that tends to be a little bit of a niche specialty, so not all of us do a lot of that care.
Okay, fantastic. That sounds really diverse. So we'll talk a little bit more about, I think, each of those and try to cover some ground with some of the things that you mentioned. But obviously, we have to talk about COVID, right? Endocrinology or Gen Peds, where we're kind of dealing with similar things. So I'm just curious, has anything changed, like in the way that you guys are seeing endocrine disorders, or have you seen anything become more common or less common? Any changes in the prevalence since the start of the pandemic of any of the disorders that you guys take care of?
Yeah, so the biggest ones relate to diabetes, and there's actually a lot of work being done at various centers looking at changes in incidence rates as the pandemic has begun. In fact, we are working on a study on the increased rates of type 2, which we have seen significantly more than type 1, although there's been a little bit of a subtle increase with type 1 as well, reported in some places. But type 2 has been a major change. And for those who don't know, type 1 diabetes involves, it's an autoimmune process where your body is no longer able to make a normal amount of insulin, the hormone we use to basically take the energy from food and use it as fuel. So type 1 is an autoimmune condition, and I can talk more about that. Type 2 is a condition where you become resistant to the insulin that your body does make. And there can be a number of reasons for that. In fact, former premature infants are at higher risk of type 2 diabetes, but the biggest risk factor for developing type 2 diabetes is obesity. So one thought is that the decreased activity levels caused by prolonged lockdowns, not being able to attend school and do usual activities, for good reasons, of course, unfortunately led to the consequences of a higher rate of type 2 diagnoses. Now, we don't know that's the link. That's just kind of one hypothesis and something we're looking at. But we have seen an increase in number of those cases.
So I think that makes sense to me, right? Because even obviously in general pediatrics, we're seeing a ton of increase in obesity for all the reasons that you mentioned. So the link to type 2 and increased incidence in type 2 makes sense to me. But what about type 1? Do we think that there's any actual like pathology, something that's wrong that COVID is triggering? Or is it just that these kids are presenting later because there's hesitancy, right, to go to a medical setting? because parents are trying to decrease exposure, or is it not really significant, the amount that you guys are seeing now?
Yeah, so type 1 is thought to be, at least in some cases, triggered by the body's reaction to a virus gone awry. So some do think that some might be susceptible to COVID, but that is certainly not something that is known yet. That is something that is still something many groups are studying. Interestingly, there has been a slow increase in type 1 diagnoses over time for many years, even pre-COVID. And we don't know why that is. If it's viral burden, if it's a different makeup of people's immune systems, don't know.
Wow, so interesting. Okay, so I want to switch gears and talk about growth because I'm sure a lot of this comes your way, different growth issues. So as a general pediatrician, usually the things that come our way are parents, concerns that the child is not growing, that the child is shorter, let's say, than the other kids or like other peers in the class. So what are some common growth things that you see by the time the child actually gets to you?
Yeah, so the first thing I want to discuss is that I think general pediatricians are very well meaning, but if you have ever taken your kid to a general pediatrician and they look at the growth chart and your kid's growing on the 75th percentile, and the pediatrician says to the parents, wow, your kid's going to be 5'8" if it's a girl or something, they should not do that. I bet you don't do that. I'm sure your practice does not do that. But be very careful, because what the growth chart looks at a young age isn't necessarily what can be expected later on. And I think setting the expectation that, as long as someone is growing, that it's hard to make conclusions about what the final outcome will be until later is important, and something that I want parents to take away from their primary care visits. Like, don't jump to conclusions that just because your child is in the 10th percentile means there's something wrong with them and they're going to be very short as an adult, because that's not necessarily even true. We see a lot of growth come to our office. One thing I will say is that if parents are really, really worried, then seeing endo is never wrong, because we can take a look at things, the whole growth chart, get what's called a bone age, which means we look at the hand and how mature it is, and we look at the growth rate and put all the things together, and we figure out if this is a child that needs more workup to figure out if something's wrong from a growth perspective. There's a lot of focus on final height, and sometimes I wish we could take a little bit of the pressure off of that and worry about what's happening in the moment. Is this a normally growing child?
So you're saying don't necessarily look at the growth chart as a predictor of final height, right? And final growth. So what's a better indication? I think I always thought that you can predict it the best by looking at parental height, right? And mid-parental height, where we kind of average and use a specific formula for if it's a boy or a girl to determine sort of where we think the child is going to end up. Is that still the recommendation?
Yes, absolutely. So parental height is a really good guide for where you can expect that child to land. And I guess what I'm getting at, I've seen it gone awry a lot, and we'll talk about puberty and how confusing that can be.
Mm-hmm.
But let's say you have parents that are on the shorter side but normal. Maybe they're 25th percentile, which for a woman would be about 5'3", a man would be about 5'8". But they've got this daughter who's always been at the 75th, 80th percentile and maybe growing steadily. However, if you go into the mom's history, you'll find out, oh, she was one of those early bloomers.
Mm-hmm.
She had her, cycle begin at age 10 and she stopped growing in 5th grade. That can be normal. That's actually it's an unusual pattern of growth, but I can talk about where the kind of beginnings and endings of normal are, because I think there's a preconceived thought that puberty happens at one certain age and there's an acceptable range that's fairly wide. But that child's growth chart might show 75th percentile, but then they're probably going to have an early spurt and they're probably going to end up 5'3", just like mom, because that's kind of where their genetics are. And that's perfectly normal. It probably doesn't need workup. It's just, that patient's version of normal. So you're absolutely right. The biggest thing to look at to see what would be an expected appropriate range for a child is the parent heights. And I do think that goes both ways. So if you have two very tall parents and there's a kid that's just hanging out at the, 5th percentile, that kid probably does need a workup. I have diagnosed growth hormone deficiency in that kind of a scenario where two very tall parents had an inexplicably short kid who was sort of keeping up with the bottom of the curve. But we did look, and he definitely had a true issue that has been treated now. So you really do need to look at genetics and parental heights to guide you there.
So that, since you mentioned growth hormone, that kind of brings me to my next thought, because even in Gen Peds, we see a lot of sort of questions about growth hormone, parents wanting growth hormone. Is that always the answer? Is growth hormone deficiency like the only real indication for growth hormone? How do you guys decide who actually gets this treatment?
That is a wonderful question. So, the approved indications for growth hormone include growth hormone deficiency, being small for gestational age, which is defined as below the 10th percentile as a birth weight. So this is usually premature infants or babies that were born inexplicably small, like less than, I think it's like 5.5 pounds, and never catching up to the 10th percentile. That's actually an indication. Having certain syndromes such as Turner syndrome or Prader-Willi syndrome. These are genetic diseases that are, very specific. And then also it was approved in 2003 for a condition known as idiopathic short stature. I like to explain to parents that idiopathic short stature does not mean my kid is shorter than I'd like them to be, or my kid is not tall enough to be the star of the basketball team. ISS is actually specifically defined as a height 2.25 standard deviations below normal. So you have to be quite short. That's like the first percentile. We will also extrapolate forward, and if someone has a predicted height in that range, like a male predicted height of less than 5'4", a female predicted height of like less than 4'11", then growth hormone can be considered specifically for just their stature without worrying about whether they're deficient. Now, they often would get testing for deficiency because you'd want to figure out why is this kid, unless you have a very short set of parents and then you kind of know why. Yeah, they can be treated. But I guess sometimes we get a lot of pressure where it's like, well, I want my kid to be 50th percentile, and it's really not indicated for that. The good news is that studies show that children who are, 25th versus 50th, until you get to a very low point, there's not really significant quality of life differences when you look long term. So it may seem like there would be when you're thinking about like the basketball tryouts in 8th grade,
Sure.
but if you actually look at lifelong happiness, your, short but normal short kid is likely to be just as happy as their tall peer.
That's good. That's reassuring, because I'm sure we get a little bit of pressure. I'm sure that a lot of that pressure comes your way also, of parents really having, sounds like what might be some unrealistic expectations and unnecessary expectations and pressure to have their kids be a certain height. You mentioned puberty and how, right, there's this like wide range. And so we may not necessarily feel that, because sometimes we hear about, especially girls, right, starting puberty on the younger side, and it makes us a little bit nervous. So what are some common, so first let's talk about like normal puberty ranges. What's the expectation? And then what do we do about kids who fall outside of those ranges, either precocious puberty starting too soon, or kids that really don't seem to be developing on time at all?
Yeah, great question. So I think puberty is so interesting, in part because there is so much natural variation. In a girl, puberty, so first of all, I guess I want to draw a line between true puberty, which in girls, we look for the signs like breast development. And in boys, we actually, the most reliable sign is testicular enlargement, which is not something you're always privy to as a parent necessarily, but their pediatrician should be checking. Um, so having body odor and body hair can mean the adrenal glands of the child is woken up. And if it's very young, that can require evaluation, but it's not necessarily what I'm referring to as puberty. I'm talking about true puberty, the onset of breast buds in a girl, or testicular enlargement in a boy. So for girls, the kind of youngest allowed cutoff is age 8. And the oldest allowed cutoff is age 13. That is a huge range. And I have a 9-year-old of my own. And now I am seeing that because she has some peers who, are clearly developing and going through growth spurts. And then she has other peers who have nothing going on at all. And it can look to a parent like something's wrong. Like, when all the kids are 18 months, they're all kind of doing this milestone. Why has it changed? It's diverged. Something must be wrong. But actually, there's just a lot of natural and allowed variation. This is another area where genetics and parental history plays an enormous role. I see a lot of girls who have early onset of puberty, who need evaluation. And the number of times that their mother tells me that she had her first period at 9 or 10, or even I had one recently, they said they weren't even 9. It's so genetically mediated. So that's really, really interesting. And you can look to the father's side as well. People forget about dad because there is no like obvious milestone there. Men think about like when their voice changed and when they have facial hair, but that's like the very end of puberty in boys. That stuff shows up like after the growth spurt, kind of like as things are like finishing out. So often boys don't really know when, or men don't even really remember when puberty just began for them.
So
oh wait, so that was girls.
So let's talk about okay, so that's, there's a wide range, and so I think that can definitely be confusing and stressful for parents. But once we've accepted that, let's talk about true precocious puberty, right? Puberty that started too early.
Yes. Well, can I give the normal range? I want to give the normal range for boys as well, because that's often confusing, and it's a little bit older. So boys,
I don't even think about boys because of what you said. Sometimes the signs are so subtle that right, it's not like overt to even remember.
Yes, and we get much more referral for girls. Actually, though, boys having puberty that's truly early is more likely to be, it's much more rare, but when it happens, it's more likely to be a pathologic condition. So if you have a boy who's showing signs, like technically it goes down to age 9, but honestly, most 9-year-old boys are not in puberty. So I'd say around age 10 is when you usually see the kind of the earliest cutoff. And then it can start as late as 14. If they're 14 and have had 0 changes at all, that is when, there would be interventions. But you're asking about treatments for precocious puberty. So thankfully, we do have some. The first thing to do is figure out the cause, right? So is this idiopathic, or meaning it just happened because it happened? Thankfully, that's the most common cause. So most of the time, we look for more concerning things, which I'll talk about, but we find nothing, which is great, because that just means, okay, there's nothing wrong with this child. We can give medicines to stop the puberty. Then they will not have any lingering issues. However, we do need to go down the road of, could there be an underlying problem? So the most common would be some kind of lesion in the brain or the pituitary. So usually if we're really concerned about early puberty in a child, they get brain imaging. In a girl, often they'll get a pelvic ultrasound to see if there's an ovarian cyst or something that caused it. And we look at labs to see if there's some underlying conditions, such as congenital adrenal hyperplasia, that can trigger early puberty. There's some other really rare things as well that we might look at in specific scenarios, but those are kind of like the main ones. So if your child's truly early, they'll get referred and we do an evaluation. One fun fact is that exposures to exogenous, meaning like outside hormones, can cause early puberty. When I was in fellowship training, I saw a family who had 2 kids that unfortunately developed deepening of the voice and body hair at very young ages, and it turned out to be due to transfer of dad's testosterone cream. So you do have to be very careful to ask about whether there are medications in the home, like estrogen creams, testosterone creams, things like that, that could potentially be contributing to abnormal puberty in young children.
I remember reading something about lavender, like lace products. Is that truly linked to increased like exogenous estrogen, or that's not a thing?
So no, it is a thing. There's been papers published. I don't worry about it so much in like Aveeno with lavender. I mean, to be completely transparent, I think I'd buy the Honest company with lavender for my own kids. So clearly, but I worry about it more if it's like a pure essential oil. And there have been cases of gynecomastia, early breastfeeding in girls and abnormal breastfeeding in boys, linked to using pure essential oils of lavender. And tea tree oil is supposed to potentially have some androgen like effects. So the biggest culprit was those very popular lice sprays that were sold for a while. I tell families they can use any essential oil lice spray they want, but not lavender and tea tree. I'm like, get the mint one, get the eucalyptus one, go crazy. It's not that I'm anti-essential oils. I would just recommend you avoid those 2.
And are those changes reversible if somebody did have exposure to, let's say, even dad's testosterone cream or like one of these essential oils? Once we eliminate that as a trigger, are the puberty changes permanent?
I've seen breast buds go away after we eliminated a certain culprit product, but you never know if like they had a little bit of bone age advancement during that time. I mean, we want to avoid these things if possible. Those poor kids with the testosterone. I mean, I think probably a lot of the symptoms went away, but again, I worry about, and when I say bone age advancement, remember I mentioned earlier in this, just for the listeners, that we do a hand x-ray to basically see how much time you have to grow. So, a normal 7-year-old's hand might look 6, it might look 7, it might look 8, and that's how close the bones are to fusing. And if you have exposure to an outside hormone that's really prolonged and severe, your bones can get closer to fusing, and then that child can end up shorter than they would have been if they hadn't had that exposure. So that's not good.
Wow. Okay. All right. So let's go back and talk a little bit about diabetes. So we talked about type 2 and how it makes sort of sort of makes sense that we're seeing it may be a little bit more frequent now that people are home more, right? Moving less, kids are moving less. But let's go back and talk about type 1. So you told us briefly about it. Just give us again, if you don't mind, give us a definition, like what is type 1 diabetes? And more importantly, when should parents start thinking about it? Because I think sometimes the presentation can be very subtle in the beginning.
Yes, it can be subtle. And the first thing I'll say is that if you've had a child that's diagnosed, you did nothing wrong by missing it, because most people do. So there's not, don't ever have that guilt. Like, I should have seen this and I missed something. Because number one, that's common. And number two, we don't really have good preventative therapies yet. So, as long as your child did okay, then it wouldn't have really changed the outcome necessarily, except that it's nice to avoid, what I'll talk about, what's called DKA, or diabetic ketoacidosis. So the subtle signs you might see, as I mentioned, your body is not making enough insulin, which is the hormone that allows us to absorb fuel from our food. Take it, put the sugar into our bloodstream and then into our cells, and then use it for fuel. So if you can't get the fuel into your cells, what happens? Number one, you are going to get a lot of it stuck in your bloodstream so that your blood sugar gets very high. You're going to feel very tired because you can't use that fuel. You're going to lose weight because you can't use that fuel. You're going to be kind of peeing it out instead. And it's going to make your kid very, very thirsty, because their blood becomes concentrated with so much glucose that our brains are smart and they say, why is my blood so concentrated? I need a lot of water to try to flush this out. So they'll drink and drink and drink and pee and pee and pee, and often they will have weight loss. Although so many parents will say to us, it's like the same thing every time, I thought they were just getting taller, which I totally get, because when your kid stretches out, like, you can see the same kind of thing. So it can be kind of subtle. And a lot of times they won't realize it was actually weight loss until they go to the pediatrician, and the pediatrician's like, oh, you lost 3 pounds. Like, that's not normal. And then you go down the road of, was there increased thirst? Have they been needing to get up and use the bathroom at night? If it's a young child, have they been potty trained? And then they start bedwetting. We get a lot of new diagnoses either at the beginning of school year or at the end, because they're like in a different environment, and either a teacher will pick up on that increased need to go to the bathroom, or the opposite. They've been at school and now they're home and their parents like, why are you peeing all day? So that's when we'll see a lot of new diagnoses. And those are the signs to watch for. And it's so easy to test for. If you're ever worried about that, your pediatrician can do a finger stick blood glucose and a urine, and this can be like ruled in or out like very, very quickly. So I think if you're ever wondering, totally bring that up with your pediatrician, because we might as well do a screen and make sure that that's not what's going on.
For sure. So once somebody's been diagnosed, unfortunately, we see this every once in a while where they just have, very difficult disease to control, where it's either just uncontrollable diabetes or the family's, not really complying with the treatment. I'm sure you see that even, tenfold. So what are the dangers of that? What are the dangers of poorly controlled type 1 diabetes in kids?
Well, I do want to let go of the myth that, it's impossible to control in some kids, and some people just have a really bad kind of diabetes that's like, we have a lot more tools now, and we've seen that it's probably just that we didn't have as good treatments, and now they're a lot better. So we're seeing that a lot less. But if you do have a child with diabetes, or if you're an adult with diabetes, the dangers are more, well, there's short-term and long-term dangers. So the short-term dangers, as I mentioned, there's something called diabetic ketoacidosis. When those cells are starving for fuel, because as I'm saying, you're just peeing out all your sugar that you're eating. And when I say sugar, that's kind of a marker for any kind of calories. It could be any food, really. Then your body has to make an alternative fuel, and it's called ketones. If anybody has done the keto diet, they know exactly, they've heard of ketones. But ketones, when they get to a certain level, and if you have no insulin on board, can become toxic. They're not likely to become toxic in a normal person just doing the keto diet or fasting or something, but they can become toxic if someone is not producing insulin. And so the blood gets very acidic, and kids can get very sick with a lot of vomiting. In fact, one interesting symptom some kids present with, which is unusual, is shortness of breath, because when your body becomes so acidic, it's your body's way of trying to mediate that. So again, just adding to that symptoms to watch for. If your kid has been losing weight and is thirsty and now they're sick and you see them looking like they have an asthma attack, they need to be checked immediately. That's a hospital kind of admission type of a thing. And that's how it can show. So that's kind of the short-term danger. We can treat it in the PICU, ICU, pediatric ICU, with an insulin drip. And most kids do really, really well and fully recover. but it is a life-threatening condition. So that's the short term. The long term is that if you have elevated blood sugar levels, for years, and it's a chronic thing, that's very bad for certain small blood vessels in our body called microvasculature. Especially affects our kidneys, so the blood that feeds our kidneys. It affects our eyes, and to some extent, it also affects like our peripheral vessels in our legs. So that's when you hear about somebody who had to have like an amputation or went blind from diabetes. Now, that's not something I ever want parents to think about when their kid is first getting diagnosed, because truthfully, if you do the basics to care for your diabetes, those things really are so much less likely to happen. And in fact, if their A1C is controlled at the goal, pretty much not going to happen. So I think our tools are also so much better now that a child getting diagnosed now, doing less work than they had to a century ago. Well, a century ago, you could barely do anything, but even like 30 years ago, is going to do so much better. I always tell patients they can have as many kids as they want. They can still be an athlete. There are Olympic athletes that have diabetes. There were like 2 American Ninja Warrior competitors who are teens who have diabetes. Like, you can do anything and you can live a completely long and normal life. It's a condition that requires a lot of work and upkeep.
So let's talk about some I guess developments, right? Or some things, not necessarily even for diabetes, but certainly we can touch on that. But just in general, like in pediatric endocrinology, because it sounds like it's such a developing field. It's so exciting. You guys are having so many new treatments. So what are like maybe like your top 3, top 4 like exciting new treatments that you feel like really have revolutionized the way that your patients are able to care for themselves?
Yeah, so one of them would actually relate to, 2 of them might relate to diabetes. So I'm going to combine one of them into one. So back in the day, kids had to do a lot of pricking of their finger. That was like the classic thing. But now we have what are called continuous glucose sensors, which can be worn on the body. And almost all of our patients get them shortly after diagnosis, which almost eliminates the need for them to prick. They no longer need to be calibrated. They are so wonderful now. They go to an app on your phone, so our patients can just look at any moment and be like, oh, my sugar is 117 and going down. It's just so much better than it was previously. And my combo with that is there are now smart pumps, where the pump not only gives insulin via pump, which is better than having to give injections, but it looks at that data. You don't have to look at it. Well, you still have to look at it, but it will look at that data from the sensor and adjust the insulin going in accordingly. So it's like, they've called it artificial pancreas. I don't really like that terminology because I think it's misleading, but it's an amazing tool and has helped many of our patients' parents sleep so much better through the night than they ever were before when we didn't have that technology. So I'd say that's number 1. Number 2 would be, well, this is kind of up and coming, but there are some weekly growth hormone preparations in the pipeline. I've never even gotten to try them on any patients yet. They are not FDA approved, but I think that's something very exciting because growth hormone does involve a daily injection, and to someday think of being able to give them less often would be really wonderful for kids. And then I guess, well, a third is probably the increased number of genetic diagnoses we're able to do at more and more affordable cost. Now, sometimes we don't do them directly. We send our patients to genetics because we don't want to miss anything, and they're the best at knowing the exact right test to send. But the number of like more specific molecular diagnoses we're able to make now is much, much better than it was even 10 years ago. So I'd say that's added a lot to our field.
Awesome. That really sounds exciting. So I'm happy for you guys. I'm happy for your patients mostly. I think that continuous glucose monitor was probably totally revolutionary because I wasn't in training that long ago, but even then I remember, a new onset was a huge deal, and obviously it still is, but a big part of it was like learning to check your sugar and how often and when and to do all that. And so to now have it be less cumbersome, I think is probably a huge relief.
To be fair, we often train our patients in the beginning still to learn how to do that. But yeah, quickly after they're able to transition. And picture being able to watch your kids' blood sugar when they're in school and like know that they're okay. It's like amazing.
For sure. I think that's great. Okay. Well, we covered a lot. I feel like there's so much more to talk about. Endocrinology, I think, is so fascinating to me. And I really appreciate your time and taking time out of your busy day to discuss this with us. So thank you so much.
Thank you so much for having me. Happy to come back anytime.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.